I'm very pleased to be able to participate in this program. I have great admiration for the organization's accomplishments, particularly with regard to patient education. So I'm going to speak about small cell lung cancer, and this has been a bit of a tough nut to crack. It is a lung cancer that we made great accomplishments in 20 to 25 years ago, and not much has changed. Let's talk about it in general. I'd just like to give you a little bit of an outline as to what I'm going to be speaking about. We'll go through a little background of lung cancer, but particularly small cell. We'll talk about how patients present, the staging, and the current treatment. We'll talk about chemotherapy, radiation, and surgery, although surgery has much less of a role in this particular lung cancer. And I just have one slide about future directions, and I'll just mention a few things that are happening with this particular disease. Small cell lung cancer is actually known as a relatively fast-growing tumor, and patients already often know about this when they come to see me. In the last number of years, it's actually been decreasing in incidence. Some people feel, and I think this is probably the case, is that it may actually be related to a difference in smoking patterns that occurred in the 1950s. We'll talk about that a little bit more in the subsequent slides. In patients who present, many already have cancer cells that have spread to other organs outside the chest. Because this is a fast-growing tumor, however, it does respond relatively well to chemotherapy and radiation. And as I briefly mentioned, surgery has a fairly minor role in this disease at this point in time. Just to give you some background about lung cancers in general, they are not the most common cancers, but they are the most common cause of cancer deaths in both men and women. These statistics are from 2010, but not really much has changed. You can see that as far as the incidence of lung cancer, we have over 200,000 cases per year in men and women, with approximately 75,000 deaths from all lung cancer. In terms of causes of lung cancer, unfortunately, smoking remains the top 9, with the 10th one being some environmental exposures and possibly some genetic predisposition. And in small cell lung cancer, smoking is very, very closely associated with the development of this disease. In fact, I was trying to think about this, and I frankly cannot remember if I actually have seen a patient who never smoked who ended up with small cell lung cancer. Here's the histologic types of lung cancer, and you can see non-small cell, about 85% of lung cancers are in that category. When it comes to small cell lung cancer, however, it's around 15%. And years ago, it used to be anywhere from about 20 to 25%, although I still see a fair number of small cell lung cancers. Why did the incidence go down? There was also actually a change in the types of non-small cell lung cancer. Many years ago, squamous cell lung cancer was the most common non-small cell, but it's now adenocarcinoma. Back in the 50s, there was a change in the way people smoked. They changed from non-filtered to filtered cigarettes. And this is thought to be part of the etiology of why there has been a change in incidence of some of these cancers. When people have filtered cigarettes, the larger carcinogens or particulate matters actually are filtered out, but yet the smaller carcinogens still get into the lung. In squamous cell cancer and small cell lung cancer, they tend to be central in their nature. And if you have the carcinogens getting out to the periphery of the lung, you'll see more adenocarcinomas, which tend to be more peripheral. So this is what's thought to have resulted in a decline. But it's still 15% of lung cancer cases. I actually did the math here, and when I take the over 200,000 cases of lung cancer seen in the United States per year, and you multiply that by 15%, you still have over 30,000 cases of small cell lung cancer. This is quite substantial. So it's still a very important cancer in the sense that we need to develop a lot of treatments for it, because there's still a lot of patients who have this particular disease. I think I tend to see maybe more than average because I work in the metropolitan Detroit area, and we unfortunately still see a lot of smoking in our state and in the area in Detroit. Maybe in other states where the smoking is less, you might see less, but I still see quite a bit. This is hardly an orphan tumor. This is actually a slide that talks about different presentations of lung cancer. This is for all comers. There are some patients who are asymptomatic, and the cancer is found incidentally. That doesn't often happen in small cell. Local symptoms are still the most common, and that is cough, occasionally coughing up blood, presenting with a pneumonia, shortness of breath, which is what dyspnea is, pain, wheezing, and you can also have other symptoms. You can have paralysis of the diaphragm, which is what this phrenic nerve paralysis is. You can have difficulty swallowing, which is what dysphagia is, and that might happen with a small cell lung cancer because of the central nature of the disease. Stridor, which occurs when you have pressure on the windpipe. Superior vena cava syndrome, which is a syndrome that results from the pressure of the tumor on major veins, and patients often present with swelling of the face and arms. Pleural effusion, which is fluid in the lung. Pericardial effusion, which is fluid around the heart. Hancock syndrome, not very frequently. And with small cell lung cancer, you can also present with problems related to metastatic cancer. In fact, I saw a patient just the other day who came in with pain in his abdomen, and that's because he had liver metastases at presentation. These symptoms tend to come on fairly quickly with this disease. With non-small cell lung cancer, the symptoms can come on a little slower. With small cell, though, because of the fast growth of the cancer, they tend to come on a little quicker. And very often I'll have patients tell me, I was fine a couple of months ago, and no, I'm not. And that's because of the aggressive nature of the disease. I do have one additional presentation, and that is what is called a paraneoplastic syndrome. And they occur because of the presence of the cancer, not because of the spread of the cancer to a particular organ, but just because the cancer is present in the body. And what often happens is that these cancers can make a hormone or a substance that causes other problems. And we'll talk about that on another slide. Small cell lung cancer is very much known for presenting with paraneoplastic syndromes, even though most of the time people don't have them. And they're relatively rare, but it is the most common cancer to cause these. I already mentioned that small cell lung cancer tends to be more in the center of the chest. Rarely does it present as a solitary pulmonary nodule. That's what SPN is. Probably less than 5% of the time. It says 4 to 10%, but I'd say less than 5%. The tumor tends to often be present if you look into the bronchial tubes under the lining of the bronchial tubes, which is what the mucosa is. It tends to be under there. So sometimes you don't actually visually see it when you do a bronchoscopy, which is a scope into the trachea, into the bronchial tubes. It almost always has already lymph node involvement at the very least, and the lymph nodes are often in the center of the chest, and they can be fairly bulky. It often spreads early. So via the bloodstream, it can spread to other organs. And it likes to go to the liver, it can go to the brain, it can go to the adrenal glands, which are glands that sit on top of the kidneys, and it can go to the bone. That would be the most frequent places where it likes to metastasize. It is associated with what we call paraneoplastic syndromes. There are many, and actually that's a whole other complicated talk when you talk about these syndromes. But the ones that are most associated with small cell are what are called SIADH, which is overproduction of a hormone called antidiuretic hormone. And these patients can present with a low sodium. And that in and of itself can have a lot of symptoms, particularly fatigue, depending on how low the sodium is and how quick it gets low, you can have quite a few symptoms. Most of the ones are fatigue, mental status changes. This goes away, of course, when you treat the tumor. The other syndrome that can occur with small cell lung cancer is Cushing syndrome, where you get an overproduction of steroids. The most common things that happen with this are muscle weakness, high glucose, sometimes a high sugar, and low potassium. Those are the more frequent things associated with Cushing syndrome and small cell lung cancer. The other paraneoplastic syndromes that are often associated with this disease are neurologic symptoms. And you can see one up on the slide, Lambert-Eaton syndrome, which is a type of muscle weakness. There are other neurologic syndromes that can present, what we call peripheral neuropathy, where we get numbness, particularly in the lower extremities. You can get changes in the retina of the eye, and you can get what's called cerebellar degeneration, which is a syndrome which affects the brain and affects balance in particular. Now, interestingly enough, these neurologic syndromes can precede the actual diagnosis of the lung cancer, so they can come before you can actually see it. And it's thought to be related to the fact that both the neurologic system and the lung cancer itself have a common base. The patient's body actually produces antibodies or tries to get rid of the cancer with their immune system. And the antibodies that are produced not only try to go against the cancer, but as an innocent bystander, the neurologic system gets affected. So that's the theory behind what happens. These don't always get better with treatment because the nerves don't heal as well as the rest of the body, but they can get better. The endocrines here, the more common ones associated with small cell are hyponatremia, which is this SIADH I was explaining, and Cushing's syndrome. Here are the neurologic ones. These are also the ones that are more commonly associated with small cell lung cancer, pretty much. The other ones are with other lung cancers. When someone has small cell lung cancer, we like to get going with treatment as quickly as possible. But I still think it's important to do a staging workup because treatment changes depending on the stage, as with non-small cell lung cancer. Very often, patients do have a high frequency of metastases. About two-thirds at the time of diagnosis will have metastases to various organs when you actually do staging procedures. What is the basic workup? It's a good history and physical by the physician, a CBC, a standard chemistry panel. A lot of people like to do an LDH, which is a non-specific measure of the amount of tumor. A CAT scan of the chest and the abdomen to include the liver and the adrenal glands that sit above the kidneys, and MRI of the brain. And this is actually, in my opinion, better than a CAT scan because the MRI can pick up very small metastases, and small cell lung cancer can present that way with very small metastases. So I'd prefer to see an MRI if possible. If there are no other metastases, then a bone scan should be done, or if someone has symptoms, of course, it should be done. Now, interestingly enough, a long time ago, before Dr. West was born probably, but I was practicing, we used to do bone marrow examinations on these patients. What they really found out was that small cell lung cancer can go to the bone marrow as well as to the bone, but the bone marrow is usually not the only site of metastases. So we don't really do it too much anymore. The only time I do is if we have an abnormal blood count at the beginning before you even start treatment. Then you sort of need to know if it's because there is an abnormality in the bone marrow or if the cancer is present, because you might manage the patient a little differently. So that's the only time we do that now. I just actually have a picture of what small cell looks like under the microscope, and you can see it here. This is another picture of an H&E stain. This actually used to be called oat cell, and you may still hear this term periodically, although not too much anymore. And the reason it was called oat cell was that the cancer cells actually had the appearance of oat seeds. This is actually a chest X-ray of a patient with small cell. You can see the tumor here in the left part of the chest. This is the heart, and also there is some tumor here as well. And this picture here is actually post-treatment of this patient where you see reduction in both areas of tumor. The staging is a little simpler than what we see with lung cancer. Basically, the cancer is staged as limited or extensive. Limited stage represents about a third of the patients, and it's confined to usually one side of the chest. It can include the lymph nodes. The way it's presented is if the area of the cancer involvement can fit within a port or the target used for radiation therapy. For instance, if you have cancer spread to both lungs and it's extensive, that would make it extensive disease because you could not fit all the disease within one radiation field. But if you have it on one side, including the lymph nodes, then you could. So that makes it limited disease. So it's a little simpler than the non-small cell staging that we use. Extensive disease basically means it's not limited. Any disease outside the chest makes it extensive. Also, if you have a fluid within the chest that has cancer cells in it, that generally makes it extensive. Also, if you have disease on the other side of the lung, like I mentioned before, because that can't really be put within a radiation portal. So you have limited and extensive.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts and the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.